Your life, sir.
Hi guys, good evening once again, and great to see this paper. And I'm so happy that I'm so confident that all of you have done well. All my PrepLadder students and all my students who've taken the live class with me, whether you were in Hyderabad or in Delhi or in Jaipur or in the South, I'm sure you guys have done a great job because I'm so confident because whatever we've discussed in the notes has come in this exam. I mean, like, I'm bubbling with excitement because I feel that this is that kind of paper which gives you the confidence after you come out. And this is what happened before I had gone for. One or two places in Delhi, I had gone to just say hi to all the students. I met a few. All of you were in quite a hurry, but then the students who met me, they were quite happy. And of course, before the exam, when I went, I said, I hope the gynae paper is coming through the PrepLadder notes which we've given you, or through the workbooks which we've given you in the live classes. And after seeing the questions, it's exactly like that. So I hope all of you did well. And in the other 18 subjects also, I hope you've all passed the exam. Best wishes for the best results to all of you. All right, guys. So let's start the discussion. And this is the elite plan, which we are giving you at a 4,500 rupees off. So enroll for it right now. Guys, we'll get to the first question, which has come. And let's see how many of you joined so far. Okay, not many people have joined so far, but I hope all of you join very fast. Otherwise, you can always see this on the recorded session, right, guys? Chalo. So, well, the first question is, in shoulder dystocia, when the anti-shoulder is delivered, after what time of delivery? Okay, this is just a recall which has come to me around, so pardon the language. How long does it take to call it a shoulder dystocia, meaning that the head of the baby is out and the shoulder has not yet come out? So when do you say that it is shoulder dystocia? So if the head comes out and the shoulder is stuck, I mean, you're going on pulling the head and the shoulder is not coming, of course, you should not pull anymore because you're going to cause a brachial plexus injury. So when do you say that it's shoulder dystocia? So from the delivery of the head to the delivery of the shoulder, it takes at least, if it takes more than 60 seconds, then we say it is shoulder dystocia. So yes, this is a straightforward question which has come in our discussion so many times, and hope all of you got it right. And please remember, for the treatment of shoulder dystocia, always first do the Mac Roberts maneuver. Okay, first do the Mac Roberts and then do the suprapubic thump or the suprapubic pressure, like we say. We just give a suprapubic thump, a gentle, a firm push just above the symphysis pubis to disengage the shoulder. Okay, so Mike Roberts maneuver, you know that it is flexing of the hip joint and more than 90 degrees. So that is done for most. You know that any woman is delivering, also we make her hold her legs and pull the legs towards her and then push. So that is done for all deliveries. In this shoulder dystocia, the first thing instinctively any obstetrician does is makes the hip joint flex a little bit more. In fact, the interns come very handy at this time. You guys will be doing this for us when you see me in the labor room, that your interns will help the lady flex the legs more than 90 degrees. So that is what is done. McRoberts maneuver, suprapubic pressure. And of course, if this doesn't work, we can do the Woods corkscrew maneuver, Woods maneuver. And if that doesn't work, then we can go ahead and do the Java-Nilly's restitution. Of course, there's another maneuver, which is the all fours maneuver. The woman is on all fours, and then she's the knee chest position. In that position, also we can take out. So there are many maneuvers which are described, but you should know these four at least. All right, guys. So I hope all of you got this correct. Let's move on to the next question. Are you guys asking me something about this? Let's see the chat. Right. So let's move on and see the next question. Edematous villi with chromosome XY was found. What will be the diagnosis? So if you see, and if you see on the histopathology, you see the villi edematous with vesicles, and there is the chromosome is XY. So what kind of mole it is? You know, it is basically what they're trying to ask you is about the molar pregnancy. But yes, more information should have been there. How the question was asked is what is very important. So That's why I think the question recalls are always a little bit of problem. But yes, if the villi is edematous, then we're thinking in terms of villi which is full of fluid, hydropic villi. So that's why hydropic change in the villi is what is suggestive of a vesicular mole. So yes, vesicular mole, the most common karyotype is the 46XX when it is happening in a empty oocyte. All of you know, when an empty oocyte, no maternal genetic material, there is nothing from the mother, and the father sends in a 23X sperm, and then it can undergo a endoduplication, like we always say. An endoduplication will make the 23X. There's nothing from the mother, there's 23X from the father, is going to endoduplicate and start becoming a 46XX. So that is what is the common method of a vesicular mole formation. But sometimes what can happen, an empty oocyte. Please remember the punchline is empty oocyte. So yes, if there's an empty oocyte which gets fertilized by two sperms, okay, it could be a 23X sperm here and a 23Y sperm here. Then it's going to make a 46XY karyotype in a case of a complete mole. Yes, it can also be that there can be an empty oocyte which gets fertilized by a sperm carrying 23X and another sperm carrying a 23X. So then again, it can become a 46XX. So please remember, a complete mole. A complete mole is mostly because of this first method of formation, and it is discussed in your PrepLadder app very well, and we've done it even in your rapid revision. I'm sure all of you knew this very well. All right, guys. So let's move on and see the other methods. What are you guys asking me? Rishabh, yes, FMG exam is equal to the PG exam. Now, yes, I would say that almost 90% of the questions are like that. Yes, 10% of questions, they give you the easy questions so that you feel comfortable, because since you have not read primarily in the country, I feel that they give you 10% questions which are somewhat easy. 90%, I feel there is a limited difference. I mean, I will not say, if you actually ask me, it is the same preparation and it's the same topics. It's just that the 10 questions, I think 10% questions are given for the sake of you knowing, okay, this much you are supposed to know. If you know this much, then you're most welcome. That kind of questions are there, right? But 90%, it's just as same as the NEET PG exam. So good. 46XX was given. So that's what makes sense. If you had given me the right recall, whoever's given me the right recall, if they written 46XX, then it would have been very simple. I didn't have to teach you. But good, we had a good revision about how vesicular moles can be formed. Okay, complete mole. All right, guys, let's move on. Last question answer. OCP. Is there some question which I missed? Oh, thanks for reminding. It went too fast. Aju Medic. Okay, thanks for telling me that. I think two questions missed online. Yes. So this question is done. Edematous villi with chromosome XY was found. What will be the diagnosis? Correct. This is done. This is a complete mole. That's the answer to this question. And in a case of a partial mole, you'll see a fetus also. When you see a fetus and a placenta which is looking degenerated, then of course ultrasound could give you an indication. Not very good. Then what else can give you indication? That the histopathology will give you the indication. All right. And even if histopathology doesn't give you the right kind of an answer, then the last line of defense is the immunohistochemistry. I'm sure all of you knew that. Immunohistochemistry, we'll see, and with that the P57 staining, immunohistochemistry staining will help you, and that is because of maternal contribution, P57 immunostaining. Chalo, let's not get into too much of theory. This was a simple question. Let's go to the question which I missed. A 27-year-old woman presents with irregular periods, acne, excessive hair growth. So this is a typical case of PCOS. Come on, guys, this is that question which all of you have been told so many times. It's an often repeated question, and you guys must have just jumped on the answer. What did you say, guys? Lifestyle management. I'm sure you said that first. All right. Obviously, tell the lady to lose at least 5 to 10%. 10% weight loss. That's the most important thing. A lot of 30% women ovulate just by this weight loss. And then we'll tell the woman to have, yes, a diet, and we'll tell her to exercise. Okay, this will help most. In my hospital we have, and even when I trained in CMC Vellore, we used to have a dedicated gym for the women who used to come to OPD. So when they are coming to OPD, before coming in talking to us, we'll always check the weight, and if the weight is going low, then we are seeing them in the OPD. If they're not, the weight is not low, they'll say, okay, spend some time in the gym and then come to and talk to us. Some women will take the gym membership. It's a courtesy membership. It's just that they have a card, and in that card will keep writing their weight as they come in. So they'll come regularly to the gym. They'll spend 1.5 hours in the gym and then come to us in the OPD. So yes, that is part of many of the hospitals. All right. So yes, lifestyle modification, good one. Ovarian sealing, ovarian drilling, you mean to say? Oh, yeah, right. Ovarian drilling cannot be the first procedure. When we do the drilling, surgical management of PCOS is ovarian drilling. That's the last option. We never go for the drilling as the first management, because we say that most of our medical management, first the diet, then the medical management should be able to help a woman with PCOS. Those cases which are not responding to a regular medical management, then we think in terms of drilling. That's a surgical intervention procedure. We have to do a laparoscopy and then do a drilling. So more or less patients will respond to medical management. Yes, we have done drilling many times. So generally the trick is that if the AMH is high, then we go ahead and do the drilling. All right, AMH is very high. Oh, you marked drilling. All right. I hope you made up with the other questions. Other questions in gynae were fairly simple. So let's move on and see the other things. Let's see the next question. Which is the hormone check for pregnancy at home? I mean, the question again, please, I have not changed the question because I got them some time back, and I knew you know the question. So I've not changed the language of the question. So pardon me for that. But yes, the question is, what is the hormone which is utilized for doing a home pregnancy test? That's the basic meaning of this question. So I'm very sure it is a beta HCG. Of course, you know that the HCG has two subunits. HCG has two subunits, the alpha HCG and the beta HCG. But this alpha HCG is like the alpha TSH and also like the alpha LH. So if you're measuring the full HCG, then you may have an erroneous value, erroneous high value. So that's why the beta HCG is measured, because it is specific for pregnancy. You guys know it very well. I know that. Okay, guys. So the answer is beta HCG. Let's move on to the next question. OCPs are not protective for. My favorite question. When we are discussing OCPs, we keep telling the benefits of OCPs. Yes, it's a low estrogen condition. It reduces the endometrial thickness. It reduces bleeding. It reduces menorrhagia. Reduces the endometrium. So many benefits we keep rolling out every now and then when we meet. But yes, what is that one thing which it does not prevent? Yes, all of you know, it does not prevent CA breast. It does not prevent CA breast. We know that very well. Please remember one thing. Yes, it reduces benign breast diseases. It reduces, of course, all those mentioned here: colorectal cancer, endometrial cancer, ovarian cancer, all of these reduces. But it does not reduce CA breast. Now, it does not increase CA breast also. Remember that. So the incidence is unchanged. So this is a very good question. If it has come, OCPs are not protected for CA breast. That's the answer. Does it increase CA breast? No. Till the latest Williams obstetrics, 26th edition, they have said that it is not increasing CA breast. There are some data here and there in a lot of journals. We know that, but majority of the journals saying that it is not increasing the incidence. So we have to see what is coming in the books. One new journal comes out with one new finding. Till it is mentioned in the regular books, it does not become a fact. Okay, there's a lot of journals say a lot of contradictory things which we are teaching to you. So you have to stick. Always my advice to all PG entrance students and the MCI students, and I'm sure a lot of you PG entrance students are seeing this because you want to revise for your PG entrance exam coming up. The course is the same. Please remember that OCPs do not reduce CA breast, but it does not increase. So the incidence is unchanged when somebody is taking COCPs for a long time. So that's a good answer. Let's move on. Yes, Dr. Rishabh, this question, I don't know whether it was it, which hormone causes a negative feedback of on FSH. So remember, this line has been taught to you in all the forums where I met you. FSH for estrogen and LH for progesterone. So when there is high estrogen in the body, it'll go and suppress the FSH. When there is high progesterone in the body, it'll go and suppress the LH. This guy, I mean, this information, my students, it's there in the genome of my students. It's imprinted in your genome. I know very well. Those who have sat with me from the first lecture of PrepLadder till the last one, especially the first topic on menstrual cycle basics, I'm sure you know this very well. Of course, my life students also have gone through this as always as the first topic. Kelly, let's move on. Identify the CTG pattern. Okay, there's some obstetrics coming in now. So if you see, this is the TOCO here. TOCO means the uterine contractions. This is the fetal heart rate. And they've not given I cannot see, in fact, they're too small. I believe that the fetal heart rate is stable. Let's say whatever it is, let's say around 150. It's not a fetal distress then. So if it is 150 is the baseline, and with the TOCO, see, there's a uterine contraction. See the second one. There's a uterine contraction, and with the uterine contraction, the FH has gone to the lowest. To the peak of the contraction, you see the lowest fetal heart rate. So yes, this is the safest deceleration, type 1 deceleration seen because of head compression. All right, type 1 safest deceleration because of head compression, and you know that causes the uterine contraction, causes the head compression, causes the fetal heart rate to go low. It causes vagal stimulation, fetal heart rate goes low, and it is coinciding. All right, so the safest deceleration is the early deceleration. Which is the commonest deceleration? That is the variable deceleration. All right, that is the umbilical cord compression, which is the reason for the variable deceleration. And placental insufficiency causes the late deceleration. Good. I'm sure all of you got it correct. So this is the early deceleration pattern. Of course, this is what has been given to me. As I recall, something else came. Rishabh Dubey. All right, thanks for that. Okay. Okay, let's move on. Spot the image. It looks like that there is a uterus with a balloon inside, and they're showing a syringe which is pushing in fluid into the balloon, and the balloon is going to give a tamponade. This balloon is going to give a tamponade to the uterine muscle from inside. That tamponade to the uterine muscle is going to stop the bleeding, isn't it? So this is basically the balloon tamponade or the Bakri balloon. The question generally asked in exams for PPH, I told you don't leave your rooms without reading in obstetrics 2 topics. One was PPH and one was the surveillance. Surveillance, one question has come, and PPH, one question come. This is the advice which I've given to every student in obstetrics. And of course, CA cervix in PCOS in gynae. And CA cervix is coming. There's a question on CA cervix, and PCOS already one question has come. So every time you guys ask me 4 topics, I said 2 in obs, 2 in gynae. Don't leave your room without these. And those topics have come. So spot the image. This is a case of a balloon tamponade, Bakri balloon, and we fill in this balloon with 500 ml of normal saline. Of course, it should be warm normal saline. Otherwise, you'll get a cold shock. Okay. Right. Next question. Which sign of pregnancy denotes the following picture? Is denoted in the following picture for the proper grammar here. So yes, there is one hand inside the woman's body in the vagina. One hand is on top of the mother's abdomen. And through this, you're going in, feeling through the uterus. You're trying to feel the isthmus. The isthmus is so soft in pregnancy that you can make your fingers touch each other through the isthmus of the uterus in a pregnant lady. It's a very soft uterus. That's what is known as the Hagar sign. Yes, you know that very well. Hagar sign. It is seen around 6 weeks of pregnancy. And this is something which all of you remember that I keep telling you in the class that please don't do this Hagar sign if you're not very confident, because you're going to, if you're a little careless, then you can go and press the uterus, you know, when you're not a very experienced obstetrician. So cervix is soft in pregnancy, just leave it that. And if you know this fact that Hagar sign is soft isthmus, okay, okay, you don't have to go ahead and Goodell's is a soft cervix. Osiander's sign is, you know, pulsatility in the lateral fornices. There are many signs. There's another question on signs. So, but I'm not a very keen proponent. You know, I don't advise you to go on looking for the Hagar sign, because when you are a young obstetrician, you may actually press the uterus rather than pressing the isthmus. You may actually cause an abortion. So, you know, I keep telling that don't be in a hurry to learn this sign. If you know the cervix is soft in pregnancy, and isthmus is soft in pregnancy, cervix soft is the Goodell sign, and the Hagar is the isthmus soft is the Hagar sign. More than enough. Okay, don't go and try and squeeze the uterus of a pregnant lady. Okay, I'm not a very big proponent of this sign. Okay, chalo. Chadwick sign, of course, it's coming later, so I'm just waiting for that. The instrument is contraindicated for cesarean section, obstructed labor, after coming head of breech, occipital posterior position. So I told you one thing. Remember that in the pelvis, if you see in the pelvis, if the head is like this, if the sutures are like this, okay, and if it is occipito anterior or is it occipito posterior, both of these you can apply forceps. if the suture, the sagittal suture, is straight in the anterior posterior diameter of the pelvis, then you can apply a forceps, whether it's occipito anterior or occipito posterior. So yes, occipito posterior you can apply after coming head of breech. They are not saying that this forceps, they are saying any forceps. Yes, Piper's forceps is used for after coming head of the breech. And cesarean section, yes, in a cesarean section also. This is these kind of questions can come in your exams, and there is no way that I teach you forceps delivery during a cesarean section. The classes are going to be hours and hours. Yes, we do forceps. We use forceps as a vectus for the delivery of the head when the head is deep in the pelvis. Of course, I don't use it much because my hands are so big, man. I can get into the pelvis and take a deeply engaged head and take it out. So yes, a lot of people will use a forceps, push it down into the pelvis and pull the head out when the head is deeply engaged. They use it. Sometimes the head is floating, very high floating in the uterus. Then we apply forceps and take it out so many times that way also. So forceps is used during cesareans also. Uh, Probably I should have shown you a video on that. But they're going to ask you something like this. That was, it's an endless thing. Medicine is so huge that then when they want to trouble you, they'll give you choices which are really, really, testing the knowledge, how much more you know from the basics. So this was a little too much. That forceps can be used for cesarean. Yes, of course. Any PG would know it. Let me tell you that much. Some interns who assisted a lot of cesarean section may also know it. Never mind, for obstructed labor, we will not put a forceps, please. When there is an obstructed labor, there's only one management. If you've diagnosed a case of obstructed labor, go ahead and do a cesarean section. All right. In the choices given to me, let me see what are you guys recalling. Yes, Debopam Mandal. Yes, you answered it correct. Is the history of abortion also in the male molar? So that's all right. Direct occipital posterior, you can apply forceps. Why not? You can direct occipital posterior will deliver normally. Why? Occipital posterior delivers by face to pubis. Yes, we've discussed that. Occipital posterior anterior delivers by extension. Occipital posterior delivers with extension again. And in occipital posterior, it delivers face looking to the pubis. That's those who've done my live classes. You must have seen me showing with my head and an occipital posterior and occipital anterior. Please, occipital. Remember one thing. This question, even if you're writing a PG entrance exam, there's a favorite question in INI-CET, that what is the fate of an occipital posterior in labor? They'll give you that your gynecologist done a PV, and in a PV, the gynecologist ascertains that the baby is in occipital posterior. What is your management? Wait and watch. That is the answer they're looking for. Because if it is occipital posterior, 80% it becomes occipital anterior. 15 to 16% stays occipital posterior, and that also can deliver normally. Very rarely, it becomes occipital transverse. A good obstetrician can do a manual or a forceps rotation and extraction. That is 1 to 2% of the cases. So occipital posterior delivers. Okay, so don't be in any doubt about that. सी सेक्शन में फोर्सेप नहीं करते हैं. Yes, it's a tough question. Yes, see, for me, it is second nature. I'm living this life as an obstetrician gynecologist, and we do cesareans where forceps are applied. So this is what we do for a living. So, but yes, everything what I've done, if I start teaching, imagine the. Yes, I've not taught you forceps during a cesarean session. I've taught you forceps. I've not taught you forceps during cesarean. I agree. I'm agreeing it on national media. But yes, it is done. It is done, guys. There are many things which are done and which we don't teach you. So yes, I hope some of you at least wrote obstetric labor. This is one of those questions which there was, I'm sure a lot of you came down to A and B, and with some common sense, would have said obstetric labor, the management sir has told us you have to do a cesarean section. So with that, you may have got it correct. Chalo, let's move on. See another question. Following donates with sign of pregnancy. So they're trying to show a cervix picture here. Look, this is a picture recalled by the team, and I'm sure that the picture which came in the exam might be a little different. This is looking red because the cervix is basically a pinkish reddish tissue. So that is a basic color. But if you look at the top here and look at the bottom here, there's a bluish discoloration. So that bluish discoloration is what is known as the Chadwick sign. Okay, the Chadwick sign is the bluish discoloration, and correct, almost similar picture, same picture. All right, very good recall then. So Chadwick sign is the answer here. Hartmann sign is implantation bleeding. Implantation bleeding. Again, in our app, we've discussed this, and it is there in all the live classes. This Hartmann sign I've given you. Piskacek sign is not discussed so regularly, but then is Piskacek sign is when the baby is implanted in one of the sides of the uterus. It's not in the right in the cavity. It is implanted eccentrically. This is what is a normal implantation, eccentric implantation, like we call it. All right. So when there's an eccentric implantation of the fetus, you must understand that sometimes it is implanted on one side. So what happens that the uterus enlarges like this and one part enlarges like this. I mean, of course, this is not there. I'm so sorry. Yeah, so you will see the fetus here. It is implanted here like this. So you may see this, just ignore this line, guys. Yeah. Okay, so one side of the uterus may irregularly enlarge for some time, and then the uterus becomes uniformly large. By around 12 weeks, it's almost a spherical uterus. So it's not that during the full pregnancy it's going to be regularly large. It's only for the time being. Okay, so that is a Piskacek sign. And Osiander sign we already discussed is the pulsatility in the lateral fornices. You know the fornices, right? Chalo. Let's move on. What are you guys saying? Clear blue tha question. All right, fine. So following image denotes what side of the placenta, what side, matlab, what surface of the placenta. There are two surfaces of the placenta. One is the metal surface, one is the fetal surface. So metal surface will have the cotyledons and the fetal surface will have the umbilical cord and the insertion and the membranes you'll see here. So this is what I'm holding a placenta. How to examine a placenta. I keep showing you this picture while I'm taking classes also, that you should keep the placenta on the back of your hand. Okay, and when you're keeping the placenta on the back of your hand, then you should examine the placenta after delivery, and you should see that the cotyledons are complete. So these are the cotyledons. Around 18 cotyledons are there in the placenta. These are basically the bunches of villi which are stuck into the uterine surface, and they are taking the nourishment from the mother. So this is the maternal surface, and the fetal surface is what is shown here. The umbilical cord inserting and splitting at the site of insertion. So this is the fetal surface. I'm sure all of you got that correct. इसमें तो गलती नहीं की होगी. I'm very sure. Huh? Sorry, yellow correct mark பண்ணிட்டாங்கல்ல. Sorry. அடுத்த question பார்க்கலாம். So this is, yes, another picture here. Another picture here. So this is what is we are trying to show you. The fetal surface again here. The cord is implanted, but yes, I'm trying to show you another picture. One of my patients' placenta. This is where we are showing that the placenta has the cord attached not in the center like it should. It is somewhat on the sides of the placenta. So this is what is a classical marginal insertion of the placenta or the battledore. But yes, this picture is more to show you the field surface. Yes, of course, the picture given in this PrepLadder recall is also a field surface. I'm showing you one picture from a side. This is of a battledore placenta. But of course, this is again the fetal surface. Question was, which side is attached to the surface with cotyledons is attached to the metal surface on the uterus. What is this early sign of pregnancy on TVS? Early sign of pregnancy on TVS. Of course, we always show you this, isn't it? TVS, TAS, and I show you that first thing you see is the gestation sac, and then you see the cardiac activity in the fetal node. So TVS around 4+ weeks, you see the sac, 5+ weeks, you see the cardiac activity. TS 5+, you see the gestation sac, and 6+ weeks, you see the cardiac activity. This chart is given to you in the books. And remember, the first sign you see is the gestational sac. So yes, once again, I can show you like this. Also, you see the gestational sac, and then you'll see the yolk sac, then you'll see the fetal node. So G sac, then the yolk sac, and then the fetal node. And in the fetal node, you'll see the cardiac activity. So these things you guys know very well from the class. So all of you got it correct. That's why I'm very excited about this exam, because almost everything which we discussed has come in the exam. One or two questions, one or two choices will come out of place. We cannot possibly teach you what we read over 3 years in the MD of Obs and Gynae and what we've been doing as a life of gynecologist. So yes, but for your exam, I'm sure all of you got 40 out of 40 in this. Let's move on. See, which finding are sensitive of a tubal pregnancy? So the choice again, I'm sure the recall is a little vague here, but what did you guys write? Let's see. Because there's an ovarian mass with a single layer of endometrium. Ovarian mass is not the commonest ectopic, so I'm just ignoring this choice. Adnexal mass with empty uterus sounds like a good answer. I'll take red now. Sounds like a good answer here. Tri-layer endometrium without adnexal mass. This obviously is not the correct answer because that's a normal uterus, a triple layer endometrium or a tri-layer, what he's trying to say. Adnexal mass with empty uterus and a fluid in the pelvis. So these two are looking like the choice. So what were the other choices they gave? You marked D. There was some fluid in the adnexal mass. Yes, that's a better. So you're all giving me the answers. You're not giving me the choices. So that means you're convinced that these were the choices. Okay. If you're convinced that these were the choices, then we are correct here. That adnexal mass with empty uterus. Yes, that is a suggestion. Look here. There's a uterus and the uterus is empty and there's a mass in the adnexa. There's the ovary and there's a mass here. Okay. Ovary, of course, you'll see with 2 3 follicles, antral follicles, when and a corpus luteum, you'll see like that. And then you'll see a adnexal mass. So next to the ovary and next to the uterus, you're seeing adnexal mass. And that itself is likely to suggest that if you're seeing this mass, it is suggesting an ectopic. But if there's some fluid, then it is a even better answer, because yes, if it is not even rupturing, some fluid starts coming out in early ectopic pregnancy. Some fluids, there's some blood, in fact, in early tubal abortion, some blood can keep coming out. So even without rupture, there may be some fluid in the pouch of Douglas, which is mostly blood. So yes, I feel that in the choices which have been given to me, I will go with choice D as the best right answer for this one. Right, guys? So let's move on and see what you guys have answered. I think only one question was there. Next one was something emptying the pelvis. Thin uterus without thin uterus nahi hoga, thin endometrium hoga, Varun Garg, but never mind. Other option normally had only adnexal mass and nothing more written. So I think we'll have to go with this the answer because in the recall which I've got, so I'll have to stay with that. So chalo, let's move on and see another question. A female presents with hirsutism, delayed periods, obesity. That's already, PCOS is a major question for you guys. Never leave any PG entrance or MCI exam without reading PCOS. All right. So, female presents with hirsutism, delayed periods, obesity, ultrasound findings are given below. What is the likely diagnosis? So, yes, you can see multiple small follicles, and we classically say more than 20 follicles per ovary. Per ovary, more than 20 follicles. Earlier, long back, we used to teach you more than 12, but it changed. Okay. Now it's 20 follicles per ovary, and PCOD is the diagnosis. I mean, if this question came, they're making sure that you do very well in gynae. I mean, I could not speak to my friends who were teaching you, who were taking the other 18 subjects, but at the outlook, I feel that this was a very good paper. I met the students after the first paper, and most said that it was manageable, the first paper. So first paper was manageable, second paper was easy. I guess all of you passing, right? Okay. OHS का question कैसे आता है? OHS का question will not be like this. This is PCOS. OHS question, the ovary will be with multiple mature follicles. All follicles. The picture will be like this. See, PCOS, you're getting multiple small follicles. That's the difference. PCOS ka kya? What is the punchline I have told you? The punchline I have told you multiple small follicles. So multiple small follicles, PCOS, more than 20 per ovary. All the follicles are big, that is ovarian hyperstimulation syndrome. If all the follicles are big. So that's a different thing. Gyno and PSM was superstar for me. That's good, man. 80 marks already done. And Baki Sare mein, I'm sure you got more than 60% marks. So that's it. You're passing with good marks, Dr. Rishabh. Very good. Nikhil was very happy. Moderate to difficult. Okay. Chalo, let's move on. I would love to go on chatting with you guys, but then there are other teachers waiting. What is the likely diagnosis of a given image? I mean, like, I don't know what was asked because this picture on a laparoscopy, what is given here, I cannot see any lesion. I'm sorry if it is something is there, but I cannot see a lesion here. So this looks like a normal fallopian tube to me. Let me take it black in color. Looks like a normal fallopian tube to me. The fimbriae is not seen. This looks like normal tube. This is, by the way, a bowel. Okay, there's a bowel shadow. There's not an ovarian cyst. The ovarian cyst, if they show it, should be at the place of the ovary. So it's not there. This looks like a bowel which is in the view, and this is the pouch of Douglas. This looks like a normal uterus to me. So if this was a choice, it's a normal fallopian tube. There was some lesion. Previous year topics. What did I tell you guys? Always, this is the only thing I said. Our notes, whether you have taken PrepLadder notes or you've taken my life notes, our notes and the PYQs of 5 years. So there are some topics which we can't teach you even if we teach you everything. So those few topics which we missed, those few topics you'll read when you've done the last 5 years questions. If you do this for the last 2 months, guys who are reading for the first time, if you're seeing this recorded, please mark this. Just write it. Just write it on your wall. The doctor you're teaching, who's teaching you, the doctor whom you are associated with for all the 90 subjects, the doctor whom you like, and his MCQs are there on the YouTube for the last 5 years. Just do that. I'm telling you guys, you'll pass exams easily. Okay, those MCI students who are feeling that it's a very desperate exam, all right, so you're getting desperate for the answers. But yes, NEET PG students, you have to read a little bit more than that, all right? So there you need a rank. Here you need to pass, okay? So at least do this much. Our notes and the last 5 years MCQs. Okay. White marking. No, that white marking is nothing but the shadow, the laparoscope which is put, it's got a very bright light. So these are white shadows of the, all these lights. These are the shadow of the lights. Okay. So I don't know this picture. I'm sure this is not the picture from the exam. There was a normal fallopian tube, so they just given you a normal picture kind of thing. Two white dots were marked on the tube. If there were two white dots on the tube, okay, fine. I'm not disregarding that. If there were two white dots on the tube, then on the tube, if there are white dots like this and like this, then those are known as the tubercles. And if they're tubercles, then we'll go ahead and mark genital TB. So the picture, the question which is recalled on your screens right now, the answer is that it's a normal fallopian tube. I'll have to go with that answer because there is no hydrosalpinx, there's no endometriosis in the picture given here. But if they were tubercles, then it is genital tuberculosis. So please, you've written the exam. You know what came in the exam. The picture, best recall is of what you saw in the exam, and you know in your mind. If they were those two white dots, then those are tubercles, and that is what is genital tuberculosis. All right. Yes, this is not the picture marked white lesion. Okay, fine. If they were to, this is not the picture. I'm sure it is not the picture. Nobody will take a picture from teaching centers and app based. Obviously they are having their own pictures of patients. So if they were these tubercles, go ahead and mark tuberculosis. So both ways I've given you the answer. That's why those who are watching this for the first time, it is 2025 July exam now. Suppose those who are seeing this recorded, please remember, always see these lectures which we are recalling on the YouTube. Why? Because we are discussing all the possible options and all the possible answers. You can never get this from a guide. All right. So always see these videos in addition to whatever books you're reading. You can read OBG the way I told you, my friend Sumit. Let's move on. Okay. Saima is happy. Option C, hydrosalpinx. Option C, hydrosalpinx. The tube, hydro means water, salpinx means tube. So normal fallopian tube is like this. Now, if the tube is full of fluid like this is what is called a hydrosalpinx. So classically, fluid-filled tube, hydrosalpinx, is a classical sign of, especially in India, of tuberculosis. Hydrosalpinx can be in many infections, but hydrosalpinx tube, India, think of tuberculosis. Tobacco pouch hydrosalpinx, we call it. All right. Sanjay, hello, how are you? Let's move on. There was history of fever भी दिया था. Bhavesh, Bhavesh, you've given the punchline to this question. If there was fever in this question, then please go and mark tuberculosis. Okay? Chalo. Chalo, बहुत हो गया. A lot of discussion on this question. Let's go to the next one. Now, choreographer question, so I didn't see. Anyway, we'll discuss at the end of, let's finish the questions, and whatever doubts you have, we'll try to see as many as we can. There are some teachers waiting. You have 4, 5 subjects more to go, guys. After how much time of vasectomy can we advise not to use all? I mean, you know the question. I mean, the grammar is again wrong here. For how much time, for how many months or weeks you should advise a man to use an alternative method of contraception, okay, when a vasectomy is done? That's the question. So yes, this question all of you would have jumped to 3 months, isn't it? Would have jumped to 3 months. Yes, इसमें तो कोई और आंसर हो ही नहीं सकता. And of course, or 20 ejaculates. Yes, I know that Park says 30 and Williams says 20 ejaculates. I'll have to stick with Williams because Williams is the book of obstetrics, and I also read the same Park when I was a MBBS student. So yes, I remember it was saying 30 ejaculates, but Williams says 20 ejaculates, and that's the reference book of obstetrics. So thankfully, they've not asked you 20, 30, 40, 50 ejaculates. Thankfully, that question has not come. Otherwise, 3 months or 20 ejaculates, whichever is earlier. Okay, guys. 3 months with consulting in the hospital, 4 months without hospital consider also an option. So yes, if this choice was given, after 3 months, what we should do. So since you're calling a good option, the option, if it is showing that the person had a vasectomy and after 3 months he is safe, only after I do an examination, it's basically the semen analysis. In the semen analysis, I look for sperms. If there are no sperms at 3 months, I can give him the certificate that he is sterile now, and that is the end of the procedure after 3 months. But if he's not coming to me, then we say extra 1 month you use condoms or whatever alternate contraception maybe the wife is using. So maybe she's using COCPs. So then we say 4 months without consultation. All right, but that is not the best advice. I mean, the best advice is get a semen analysis, because if somebody has not done a surgery properly, even after 4 months, he'll be pushing out sperms, isn't it? That's not the best advice. So the best advice is with the consultation. That is, you get a vasectomy done, come to us after 3 months, we'll check your semen, and if there are no sperms, then we call you sterile. Right? So that is basically the best option. Yeah, this question is coming, Sanjay. It is going to come. The safe surgery. Which vaccine is contraindicated in pregnancy? This is PSM question plus a gynae question. So I've given you the list. All of you know that varicella cannot be given in pregnancy. Influenza can be given, rabies can be given, the kill vaccine, and the Tdap, of course, is the vaccine which is given. Instead of tetanus, we give the TD or the Tdap nowadays. All the three diseases we can take care of. So yes, the vaccines which are safe in pregnancy: tetanus, diphtheria, toxoid, hepatitis, influenza, meningococcal, and rabies. Contraindicate in pregnancy: measles, mumps, rubella, MMR vaccine, varicella, and BCG. So this list, all of you know by heart, I'm sure. This is what you do in your PSM preparation. So yes, you all of this got it correct. Of course, anthrax, Japanese encephalitis, polio, and yellow fever, hepatitis are given on special recommendations. So let's move on and see which of the following drug was not given for hypertension pregnancy. Any class where I've taught you, I have told you that there is something about INI-CET exam and MCA exam that this question will always come. That which drug cannot be given in a hyper. I mean, this is something which MCI student has to know and a PG entrance student has to know, that in pregnancy, do not give ACE inhibitors. So I hope nobody has got this wrong. Please, I hope in hurry and you've not written drug of choice labetalol. Galti ye to nahi karke aage jaldi mein, because this is that easy question. Okay, I hope all of you wrote it. ACE inhibitors or enalapril. Yeah, yeah. I'm sure you didn't get it wrong, even if you were in a hurry. Lowest ureteric injury risk is seen with. Now, this is a tough question. This is a smart question, guys. What did you guys write? Yes. First of all, what are the choices? Okay, don't give me the answer. Okay, fine. Let's do this. Give me the choices. Were these the choices? Laparoscopic hysterectomy, radical hysterectomy, vaginal hysterectomy, robotic hysterectomy. Was there a open hysterectomy as a choice? Open hysterectomy or total abdominal hysterectomy, open, something like that. Was there a choice like this? Was this choice given or not? Laparotomy था ना? Yes. Laparotomy था कि नहीं? Laparotomy, yes. Was it there or not? Somebody saying it was there. Laparotomy was in the choice. Open laparotomy. Yes. Now you tell me, guys. When I become a gynecologist, when I'm learning surgery, what do I learn first as a gynecologist? Do I learn laparoscopic hysterectomy first? Or I start with assisting holding the retractor first, and then I start assisting as the first assistant, because retractor is the second assistant. Then I become the first assistant, and in my final year I do hysterectomies, isn't it? In my final year MD I do hysterectomies, and that too open hysterectomies. This is stepwise learning. Why do they teach me open hysterectomy first? Because obviously that's the easiest, that's the safest, because you see the anatomy properly and you can apply the clamps properly, and then you will reflect the bladder nicely, making sure the ureters are not cut while we're doing clamping of the uterine arteries. You have to separate the bladder before we put the clamps on the uterine artery. So this is what is fed into our genome, guys. The open laparotomy and a hysterectomy is the safest surgery. Of course, a lot of doctors will injure while that also, but that's besides the point. Okay, all surgeons have complications, guys. Come, let's not get into that discussion. The safest surgery is obviously the open surgery, and laparotomy was a choice. I'm so happy, because if these four choices you had given me, only these four choices, I would have said vaginal hysterectomy. But if laparotomy was given, then that is the best answer, guys. Laparoscopic surgery and robotic surgeries, these are all, we are having extra instruments. We are not inside the abdomen. Our instruments, of course, they are managed by us, but our instruments are operating. The error increases. I got some reference of a journal next screen. I'll show you that these injuries increase with laparoscopies and robotic surgeries. Yes, robotic surgery is very easy. Yes, robotic surgery is much easier than a laparoscopic surgery. Like if I know laparoscopy, I have to do a lot of work to make sure that I'm able to take out do the surgery of removing the uterus and then delivering the uterus outside. It's a lot of hectic work. But if you do robotic surgery, all of that is much easier, because the robot moves in 360 degrees, the instruments which we have. So suturing is easier, cutting is easier, everything is much easier for a laparoscopic surgeon if he shifts to robotic surgery. That's the advantage of robotic surgery. But the injuries are not minimized by these surgeries. All these laparoscopies and robotic surgeries reduce the scars on the abdomen, faster recovery because the abdomen is not cut. All of these are good, but the injury risk of these delicate organs will increase. So I'm sure all of you written marked open laparotomy. संजय का गलत हो गया, I'm so sorry. Change from robotic, good, Dr. DXMDD, but open laparotomy is correct. Open laparotomy is correct. See, please remember, always open surgeries are taught first to any obstetrician or any surgeon also, because they are the safest. Any surgeon does a lot of open cholecystectomies, then he does laparoscopy. Yes, of course, if I do 100 lap choles or 200 lap choles, then I'm very good in my lap cholecystectomies also, because I'm very good in my open lap cholecystectomies. So I'm good in my laparoscopic. So I'm good in my open hysterectomies. I'm obviously good in my laparoscopic hysterectomies. I will not injure either way. But if you put yourself into place, come guys, put yourself into the place. You're a third year MD doing third year MS doing obs and gynae. You're doing an open surgery or a laparoscopic surgery. Which one you'll injure more? Put it onto yourself and get the answer. Obviously, open is always the safest. Yes, this is what we're doing, guys. This is what we're living a life as. We gynecologists operate so much that we know that open are always easier. But yes, people want laparoscopic or robotic surgery because it is faster recovery and less scars and cosmetically better and all that, isn't it? So yes, go ahead and mark laparotomy and don't be scared of the answer. I've not seen my friends what they've answered, but I hope they're also answering the same. But never mind. Be confident and just go ahead and mark laparotomy, guys. Okay. All right. Thanks, everybody, Prachi and Nitin. Why vaginal is not the answer? See, vaginal hysterectomy, if you compare with laparotomy and vaginal hysterectomy, see what happens if this is the uterus. See, I mean, this is a very vague example. Suppose this is the uterus. My hand is the uterus. Now, what happens in a prolapse? The anatomy gets, yes, it totally gets inverted. See, the uterus is like that. When it goes out, the anatomy Oh, it's not a very good demo I gave you. You know, when the uterus goes out, of course, the uterus is going straight, but the bladder and the rectum gets everted. So the anatomy is distorted in a vaginal hysterectomy. So yes, between laparotomy and vaginal hysterectomy, I'll say a laparotomy and opening the abdomen and seeing the uterus properly, then you'll do the least injuries. Vaginal hysterectomy is somewhat more than open laparotomy, and laparoscopic still more. So that way, if you say, then between vaginal hysterectomy and open laparotomy, I'll answer that the open laparotomy is the safest hysterectomy. You'll have to give me that here. Come on here. The number of hysterectomies I've done in my life, and God forbid, nothing has gone wrong. Of course, laparoscopy, we had a share of injuries. All of us go through that curve, and fortunately, there were not so many. Right, guys, let's move on. I wish I'd seen the other teachers, what reason they've given you, but you have to go ahead and I've not seen the answers of the other teachers. So if there is a laparotomy given, that's the safest surgery. See, once again, when we learn hysterectomies, we are given always the abdominal hysterectomies first. And then the next step, vaginal hysterectomies are much tougher surgeries, okay? Much tougher surgeries than open abdominal hysterectomies, okay? So most doctors who do hysterectomies, they have done many more abdominal hysterectomies and a few vaginal hysterectomies in their initial years. Of course, at my stage, I don't know the number now anymore. Open and laparoscopy and vaginal and abdominal, I have no count, guys. We are not keeping track. After the first 10 years, we lose count. And I'm not even maintaining a logbook anymore because I'm not changing jobs much, God forbid. So yes, so you must understand that most of us are very comfortable when you're doing open surgery, the laparotomy. Right, guys? Ciao. So I've just given you this data here so that incidence of ureteric injuries of 1% of the surgical procedures. Ureters, this is from the British Journal of Urology. So ureters can be damaged during other surgical endoscopic urological procedures such as partial nephrectomy, retroperitoneal lymph node dissection. See, it is not just hysterectomies. There are many other surgeries which injure the ureters. Radical and simple prostatectomy, transurethral resection of the prostate or bladder tumors. Ureteral injuries can also occur after gynecological, colorectal, and vascular procedures. Now, see the data in blue. The widespread use of abdominal gynecological laparoscopic surgery has apparently resulted in an increased risk of iatrogenic ureteric injuries. It is as clear as that. All right. So go ahead and mark laparotomy as the safest. Yeah, there are a lot of data which is contradicting. You can search internet and they'll say that laparoscopic surgery is safe because if an experienced surgeon is doing, if you go to a big hospital and you check the open hysterectomies and the laparoscopic hysterectomies, you'll see laparoscopic hysterectomies are showing much less injuries. Why? Because laparoscopies are done by senior surgeons. All laparoscopic surgery is done by senior surgeons. Laparoscopy is not given by. So now abdominal hysterectomies are done by juniors also, by seniors also. So if you take the data, the surgeons, you have to equate the number of injuries by the same doctor. That data if you have, then only you'll be able to get this answer. Suppose I do 200 hysterectomies open and I do 200 hysterectomies laparoscopy, then where am I doing more injuries? That is the data which you have to see. You don't have to just see the bulk number of data of a hospital, because open surgeries are done by juniors and they'll have more injuries. So that data, which place you're taken from, will be important. Right, let's move on. We are getting into a discussion which is a very simple discussion in gynae surgeries, that open surgeries are the safest. All right, people don't do them because it gives a big scar and 6 weeks of recovery time. When I do a laparoscopic hysterectomy, today I operate, tomorrow I keep her in the hospital, one day I keep. In private hospital, they'll send them home the next day. Day after tomorrow, she's home. Okay, that is what is a laparoscopic surgery, the ease of procedures, ease of recovery, faster recovery, lesser scars. Okay, now let's come, guys. Let's change the question. All right, guys. Right. I trust all of you now. Let's move on. Post-menopausal woman presents with irregular bleeding. Endometrium biopsy shows endometrial hyperplasia without atypia. What is the likely management? Now, this is that question. Whenever I've taught you this in the class, I've written, simple hyperplasia without atypia, complex hyperplasia without atypia, simple with atypia, complex with atypia. Like that I've written. And I've told you, without atypia, progesterone is the answer. With atypia, hysterectomy is the answer. And without atypia, I've written progesterone as the answer, and I've also written M there to tell you that it's an MCI question. It's a often asked MCI question, and it has come. Yes, it has come after 2-3 years, but it is a very often asked question. It is not a regular question, but it is often asked. And I've written in the class M for you guys. If you go and see your notes, wherever you've seen this, whether you've seen this in PrepLadder or on a live class, I've written M always because that's what has come as an MCQ. So please go ahead, write progesterone. Now, between progesterone and Mirena IUCD, I would go with progesterones because Mirena IUCD, the complications of the IUCD, the failure of the IUCD, progesterones are a much longer and a much better used instrument. The tablets progesterones, these have been used for a much longer time. So Mirena IUCD is a good procedure. It's a good thing which you put into the uterus, and it's got levonorgestrel. We can use this also, but I would mark northestrone as the best answer here. Bleeding for 3 months, what is the likely? See, without atypia, I don't have to do a hysterectomy. No, I will not do hysterectomy. Guys, gynae may never say hysterectomy as the only surgery, guys. Please. The problem is that when I ask you treatment of C endometrium, then you don't say hysterectomy. For everything else, whatever happens, gynae, you keep saying hysterectomy. So please, hysterectomy is not the first answer. Please. Irregular bleeding for some time, that is what happens to all women here. Just sit down and close your eyes and listen to my question. What is the most common presentation in the gynae OPD? Any woman between 40 to 50, what is the most common presentation? One is white discharge, and the second most common is bleeding, abnormal bleeding. Every second woman has only abnormal bleeding. So you think we do hysterectomies for every woman who's walking to the clinic? Yeah, we have to find out what's wrong first. We'll do a biopsy. Always remember, do a endometrial biopsy or a DNC, whatever you call it, or a hysteroscopy. Do the biopsy of the uterus and see. That's why I keep telling you, don't say that I'll do hysterectomy first. Always say I'll do the endometrial histopathology. Now in the histopathology, it is showing you endometrial hyperplasia without atypia. If there is no atypia, what are you going to do? You're not going to do a hysterectomy. The chance of cancer is 1% to maximum 3%. Your progesterone is going to take good care of that. All right. So that's why we say go ahead and give progesterones as the best management, not hysterectomy. I will not say that. OCPs नहीं देंगे because this post menopausal woman ना चक्कर ये है कि this the problem here is that without atypia है and ये post menopausal थोड़ा सा confuse तो मुझे भी कर रहा है यार because it should be a woman between 40 to 50 with atypia. So post menopausal woman with irregular bleeding without atypia, they've complicated the recall too much here. So I'm sure they have not asked you this question. So if somebody knows the best, because it has to be a woman between 40 to 50, and that's why the answer best for them is the northeastern. Postmenopausal woman with atypia, hyperplasia with atypia, yeah, I'll still try progesterones. But I'm sure the choices were something else. The female was 49. Post also not given. See, now I'm so happy. This was not given, guys. It was a 49-year-old woman. Definitely the answer is progesterones. I'm so happy. Because itna variables nahi denge, yaar. It will not be so difficult a question that they put so many variables. So yes, a woman who's 49 and having irregular bleeding with hyperplasia and no atypia, go ahead and give progesterones. The answer is correct. 49. And Marina ICD was not there. All right, guys, it was not there in the. भाई तुम लोग का आंसर करेक्ट है बिकॉज तुम्हें पढ़ाया गया वी हैव टॉट यू प्रोजेस्टेरोन्स अदर वंदिर कपा गुड ऑल माय तमिल फ्रेंड्स प्लीज and all my North Indian friends. That has what has come. So go ahead and mark this answer. I'm so happy, guys. That is the question and that's the answer. Chalo. We have sorted this question out nicely. Which of the following serious changes are not seen in pregnancy? Please go ahead and write soft systolic murmur because the high volume diastolic murmur can never be seen in pregnancy. Till there's, of course, which is the common diastolic murmur? The mitral stenosis murmur. S3 is seen because of the the sudden filling of the left ventricle. S3 is a common thing, and loud splitting of the S1 because the high volume. Yes, this is all correct. Please note diastolic murmur. Diastolic murmur is pathological, and the mid diastolic murmur, pre-systolic accentuation, that is, of course, splitting of the S1. Yes, there can be a splitting of S1, but then that is also seen in a mitral stenotic murmur. तो थोड़ा सा यहाँ पे गड़बड़ है, बट गो हेड एंड मार्क डायस्टोलिक मर्मर तो नहीं होगा. ऑलराइट, ऑप्शंस वर डिफरेंट. Diastolic murmur is not seen. Yeah, I'm saying diastolic murmur is not seen. Which is not seen? Diastolic murmur is not seen. Answer is B. B is the answer. Option similar. चलो ठीक है. This question, yes, diastolic murmur तो नहीं होगा यार. See, other murmurs can be seen, and the loud the S3 is seen because of the rapid filling of the left ventricle. So this is fairly simple. I'm sure the medicine teacher is coming in next, and he's also going to give the same answer. All right, let's move on. What stage of embryonic development is shown in the following image? So this is the uterine wall. This is the uterus. So you have to consider on this image. Okay, that is the image. So I hope all of you got that correct, because in this image you can see that this is the tropho. This is the trophoectoderm, and this is the inner cell mass. We always teach you in the class. And then this is the blastocele. So yes, this is the day 5 embryo, which is known as the blastocyst. All right. So this is when we do IVF, we are waiting for the day 5 embryo. When I have to transfer, I'm so happy that if it's a blastocyst, you get more blastocysts, your lab is doing well. So in my lab, if I see more blastocysts, then I transfer lesser embryos because they implant better. Blastocysts implant better. So if it's a day 5 embryo in my lab, then I transfer 1 or 2 embryos. If it is a day 3 embryo, we transfer 2 or 3 embryos are transferred into the uterus. So this is a blastocyst. I'm sure all of you got it. Yes. Yes, the blastocele or the blastocyst cavity. Inner cell mass makes the fetus. I'm sure you know that. And trophoectoderm makes the placenta. Trophoectoderm makes the trophoblast, which is the placenta. Yeah, I'm sure you guys know this. I mean, we have so much of fun in the when we're teaching the app, when we're teaching the class. This has happened so many times. Yes. Okay, let's move on. See, a woman with forced delivery 24 hours ago presents with pain in the perineum. BP is 80/60. On examination, there was swelling. I'm so sorry. Swelling. There's a swelling, pardon the mistakes in the recall, and bluish discoloration. Which of the following steps are advised not to be done? So there's a swelling in the vulva after delivery, and the BP is low because the patient has a huge vulval hematoma. Vulval hematoma, what's the outside? What you see outside is just a swelling, but inside, between the vagina and the rectum, a lot of blood can go in. I've shown you that video in the app also, and also in my live classes, that there was a swelling which was looking like there'll be 50 ml blood. But when you opened the vagina, there were 2.4 liters of clots which came out from the vulval hematoma. So yes, they can have a tachycardia, a low BP, they can be in shock, they collapse in the ward sometimes. So yes, that's what happens when you're in a teaching hospitals. You have a lot of PGs doing episiotomies, and they can have vulval hematoma. So what should you do? You should immediately take the patient to the OT, give her a lot of IV fluids, arrange for blood, and do our exploration under anesthesia. So what you should not do, repair the wound in the ward. That's the last thing you should do. Give blood transfusion, yes. Shift the patient to the OT, yes. Inform a senior about her, yes, of course. I doubt if this sort of question. Take help. Yes, that could have been the choice. Definitely take help, because the patient will rapidly deteriorate if you're not fast enough. So gynae is that, I keep telling you, recently, if somebody has seen some of the, one of the places where I was discussing about how to make your life. And if you want to be a gynecologist, you should be fast on your feet, because these are all young people who are coming to you for deliveries. And if you're fast on your feet, and of course, you should be knowing about the stuff also. If you're fast on your feet, you can save a lot of young lives. A lot of young lives can be saved, because of vulval hematoma of a normal young woman. Women delivering are obviously young women, and if you can make your decision fast and take the patient to the OT and get blood fast and operate, you'll save a life. So yes, any bleeding from the genital tract is PPH. So this is also a type of postpartum hemorrhage, vulval hematoma. Any bleeding from the genital tract. Vulval hematoma, people have lost their lives. If the patients are delivered in a village and she was brought late to us, people have lost their lives. All right, guys, let's move on and see. Question is correct, guys. Some people are saying same option. Next step was what? Next step is what? Give, of course, correct. The I mean, if the question was somewhat different, correct the homeostasis of the patient. Of course, give a IV fluid, arrange for blood. That is obviously shock management is the first thing to do. But then inform senior about it. Why you? To answer such questions, I need to know the exact choices. I need the exact language. This is a case of vulval hematoma, and please do not repair it in the ward. That is definitely not done. If that was this a choice, repair the wound in the ward. Okay, let's settle the controversy now. Was this a choice that repair the wound in the ward? Was this a choice? Question is correct. This exact question, sir. Nitin is very sure. Okay, there's a lot of chat going on. Brain of Friday hours to recall. It brings. चलो ठीक है यार. Obviously, if you are a intern, then you can't even do the surgery. Inform the senior will do all the surgery. So yes, do not. What do you have to? All of this you'll do. Inform the senior, do this, do that, get the shock going, and of course, repair the patient in the OT, not in the ward. Chalo, let's go to the next question. Following image shows, of course, I don't know whether this was a question for pediatrics or for me, but yes, it looks like an open neural tube defect. The picture is looking like that to me. Was this a question, guys? Count. Remove stitches in the ward. Nahi yaar, she'll start pouring in the ward. Yes, open neural tube defect. That's a simple question. Let's not waste time. Okay, let's move on. Fetal anemia is monitored by. Now, that's a very good question. Fetal anemia, that is, of course, in RH isoimmunization, this question would have come. And when there is RH isoimmunization, you understand that a patient will have in RH isoimmunization, if the baby is having hemolysis, then we can check the hemolysis by the bilirubin in the amniotic fluid. But that was a Lilly chart, that was old. So nowadays we know when a baby is having hemolysis, the baby is anemic, and there is anemic baby, obviously the baby will end up making his heart pump more, and there'll be increased pulse rate, there'll be a hyperdynamic circulation. Why there'll be more pulse rate? Because the same blood with low hemoglobin has to be given all over to the body and especially to the head. So high flow is given towards the head. Head sparing effect is there in pregnancy and in the fetus. And in the fetus, when there is more blood going to the head, then the peak systolic velocity of the middle cerebral artery will increase. So that is the answer here. We've discussed that in the app many times in the live questions. More than 1.5 mom. Yes, all of you got that correct. Chalo. A woman has difficult labor. She was complaining of dribbling of urine 7 days after surgery. What is the diagnosis? Bang on. All you live students and all you PrepLadder students, when we discuss obstetric labor, we always tell you about, please remember, in obstetric labor, the head of the baby is pressing on the vagina and the bladder neck against the pubic symphysis. So these two places will get ischemic. In obstructed labor, in spite of good uterine contraction, the head is not coming out. This is the vagina and this is the bladder in front. And all the places where I took a live class, we've given you this VVF discussion. And all you students must be, those who attend the revision, I'm sure you all got this, because that was the first question we discussed. This head will compress the bladder neck against the vagina and the bladder neck against the pubic symphysis, and this area will get ischemic, and that ischemic area will slough off after 5 to 7 days, I told you. All right, so that is vesicovaginal fistula. Yes, that's the correct answer. What is the hormone responsible for this? I don't know. Was this the question? Woman breastfeeding and what is the hormone responsible? Because there are two answers which are immediately A and B, both are responsible. A and D rather. A and D, both the hormones are responsible. The suckling will increase the obviously the prolactin, and the prolactin will stimulate the release. I mean, will make the milk, and the letdown is because of the oxytocin. So yes, oxytocin was the answer. Yes, sir, correct. Oxytocin, prolactin was not in the option. Prolactin was not there. So prolactin was not there in the option, then please go ahead and mark oxytocin. Then that's the answer. That's the easy question, guys. That's the very easy question. Then this was, sitter for you guys. Which therapy is given in cervical cancer? So immunotherapy, hormonal therapy, targeted platinum based. See, hormonal therapy is more for CA endometrium. Progestérons are given. So yes, I don't know what targeted therapy they are trying to ask, but yes, platinum based chemotherapy. This question came last year also. That cisplatin based chemotherapy. Cisplatin based chemotherapy. This is what has come in the exams. All right, last year also. Okay, so yes, all of you got that correct. Yes. So these were the questions which I have with me. And if there's something else you want to discuss with me, I'm here with you. You can still ask me if there's some other questions, but this is what looks like the set of questions given to me. If there's something else you want to ask me, guys, along with radiotherapy, yes, even if it was along with radiotherapy, you'll go ahead and mark um, cisplatin. So chemo radiation till, yes, you know that till stage 1 to 2A1 will give uh, a radical hysterectomy is a good answer, and after stage 2A2 we will say chemo radiation, isn't it? Open laparotomy is helpful. More marks in OBG, sir. In the tough exam, give us more time to think. All right, these recalls are done over 1.5 days, so I know you guys are all tired with the exam, and I hope this is the last exam you FMG guys have to write before you start doing your internship. And all of you go ahead and do a very, very fruitful internship. Please read like me, okay? Learn at the job. Please learn at the job. See more when you're doing internship. See more cases. Every case which you see, even if it is a just a fever in the OPD, see how the medicine guys are working up those cases. Why this test? Why not this test? If you see a surgery, please learn that surgery tonight itself. When you've assisted, go home and read about that surgery. Make your internship count. I know you're dying to get into the clinics and do all that. So when you become interns, then don't look for the earliest excuse to get out of the hospital and start, just whiling off your time and everything else. So work hard in your internship. I'm sure when you see these questions, you'll understand that when you're working internship for your PG entrance exam, these questions become much more easier. All right. So, total how many questions? These are the questions which were given to me from so many sources. So, if there are some other questions, I'm here. Yeah, they think that you're practicing doctor. See, the question is, Rahul, that we have to make sure that you have learned your basics in whichever country you've done your exam. So don't feel bad. We we want you to understand the basics in a way that you can pass the exam and work as interns here. Yes, I know it's a little tough, but till you do this, I feel it's a good exam. You must pass this exam to become interns in the country. Yes, it's a little tough, and to change your way, whichever country you've done your MBBS from, to come here and start working like this, it's a little tough. Yes, we don't disregard that. But then once you do this, you will enjoy internship much more. You'll earn your internship. And that's why you guys will do better in PG entrance. All right. Oh, patient. So sweet of you to say that. Thank you. Right. So you came in my college, Orenburg, Rahul. Yes. Fahima. All right, guys. Thank you so much, Bharat and Fahima. And thanks, guys. So happy to talk to all of you, and I hope all of you have done your exam very well. And it's wonderful to take classes, whether it is PrepLadder, whether it is live, and stay connected, guys. Wherever we meet, please understand that the only option is to work hard and read regularly. If you're pushing yourself, then only you'll do well. So if you're striving for good results, you should have that fire in you. So if you're doing that in your exam, you'll definitely pass. 150 is the least you guys are going to get. You're going to definitely get more than that. And you'll earn your internship. So that's why I say, when you pass the exam, send me a message and work very hard in the internship so that you become very good postgraduates. Right, guys, signing off from here. So I hope you guys are all doing very well in your life, and may God bless you with the best results. Thank you so much, guys. Bye-bye.